Hello, hi everyone. My name is Dr. Arvaz, and the topic of today's lecture is Complete Denture Introduction and the Applied Sciences. This topic will deal with the introduction to the complete denture, what are complete denture, and what are the functions of complete denture, the parts of complete denture, and the various anatomical landmarks and structures in the basal seat area of the maxillary and mandibular complete denture and their applied significance in prosthodontics. So, coming to the learning outcomes, there are four learning outcomes expected of you. The first one being you should be able to describe the complete denture terms and consequences of the edentulous. You should be able to explain the clinical and laboratory steps involved in the fabrication of the complete denture. You should also be able to explain the applied anatomy of the denture bearing areas. And lastly, you should be able to differentiate the stress bearing areas, the relieving areas, and the limiting structures. So, moving forward. So this is a very important topic, and you do not want to be this guy if you don't have a clue of what you're doing. So coming to the introduction, let us look at some definitions. According to GPT, that is the glossary of prosthodontic terms, complete denture prosthodontics is defined as the replacement of natural teeth in the arch and their associated parts by artificial substitutes. It is also defined as the art and science of restoration of an edentulous mouth. And a complete denture is defined as a dental process which replaces the entire dentition and associated structures of the maxilla and mandible. Next, what are the functions of a complete denture? The functions of a complete denture are a no-brainer. Mainly when a patient comes to you to seek a complete denture prosthesis, there are basically four reasons the patient is there for you. The first being definitely the aesthetics. When the teeth are lost, the patient ages by a decade or two because of the loss of the supporting support to the lips, the cheeks, and the musculature of the face. Giving a denture drastically improves patient's aesthetic appearance. Second, and the most important reason a patient seeks a complete denture is because of mastication. No teeth means no mastication, and it affects the health and the overall nutrition status of the patient. The third is the occlusion, as you can see here. A complete denture occlusion is much different from a natural dentition where we have maximum intercuspation, where we have group function, we have canine guided occlusion, and so on. But in a complete denture, a prosthodontist or a experienced technician tries to recreate something called as a balanced occlusion, in which you have bilateral contact of the occluding surfaces during protrusive, retrusive, and lateral excursive movements. So this is a very important aspect of a good complete denture construction. That is, you have bilateral posterior and anterior contacts of the denture teeth during protrusive and retrusive movements of the denture. So the lastly, the fourth most important reason a patient seeks complete denture is for phonetics. You would have seen or you would encounter in the future that patients who are teachers and headmasters or speakers who seek dentures mainly because they are unable to pronounce certain words, or religious priests or bishops or alims who come because they are unable to pronounce the scriptures. So the denture, the pudding surfaces of the teeth, the palatal vault shape are highly important in producing certain sounds like S, P, Q, T, and the deficiencies in this area can result in misspelling of certain keywords and alphabets and phrases. So phonetics is another main important reason a patient seeks a complete denture construction. So moving on, what are the component parts of a complete denture? A complete denture consists mainly of three parts. That is, the first being the impression surface, which is also called as an intaglio surface. This is a portion of the denture whose contours are determined by the limiting structures and the basal seat area. This is the part of the denture which is achieved from the impression you make during the second appointment, that is the final impression procedure. This surface has to be sitting in complete intimate contact with the denture base area bounded by the limiting structures in order for the denture processes to be retentive in the patient's mouth. The next portion is called as a polished surface, which is the outer surface of the denture, also called as a cameo surface. This is a portion of the denture base or the basal sheet area which is highly polished and is in contact with the tongue of the patient, and to which the teeth are attached. The third part is called as the occlusal surface or the occluding surfaces. These are nothing but the denture teeth which are attached to the denture base and which oppose the denture teeth or natural dentition in the patient's mouth. We have many denture teeth available in the markets with hundreds of makers and thousands of models. The most common material used for the fabrication of denture teeth, as you many of you must be knowing, is polymethyl methacrylate. Nowadays, we have high impact resistant polymethyl methacrylate denture resin teeth, which are highly aesthetic, simulating the natural anatomy of the teeth. Secondly, we have also something called as a IPN teeth or interpenetrating polymer network teeth. Some examples of these teeth are biotone, IPN teeth. These polymer teeth mainly consist of polymeric chains or polymeric network of two polymers, one being the polymethyl methacrylate. So as a result of these polymer chains, the denture teeth have extremely good strength, good density. As a result of it, they are extremely color stable. That is, they do not stain easily. They do not absorb solutions or within the oral cavity, and they have high surface hardness, making them resistant to wear over a long time. These teeth are not new, and they have been used in dentistry for at least the past 2 to 3 decades. One example, as I mentioned, is biotone, and another example is portrait by Dentsply Sirona. So, moving on, the third, this is purely for historical significance. These were the porcelain denture teeth, and an example of porcelain denture teeth were the True Bite BioBlend and the New Hue vacuum fired porcelain teeth. Now, the reason porcelain teeth are not being used today is that porcelain teeth do not have a chemical bond with the denture base resin because they are a different material. This is made of feldspathic porcelain, whereas the denture base is made of polymethyl methacrylate. So, in order to retain the porcelain teeth into the denture base, there were pins and posts on the intaglio surface of these teeth, but to hold or retain within the denture base. But in spite of these, denture porcelain teeth debonding was quite common in the olden days. Another reason is that you cannot trim the porcelain teeth, it is very difficult to trim them, and you can only use porcelain teeth in cases where you have sufficient inter-arch space. In many cases of denture construction, you will not have sufficient inter-arch space, and mostly the inter-arch space is reduced. So, as a result, these teeth are not an option in today's world. Lastly, we also have now something called as a milled denture teeth. Usually, you have separate blanks for the denture base and for the teeth, and the teeth mold is selected from a library within the software, and it is milled using the polymethyl methacrylate tooth colored blanks, and then these teeth are then attached to the denture base, which is milled, also milled from the same milling machine using a flowable resin material. You also have 3D printed teeth, but we will not go into those details because it is not within the scope of this lecture. Moving on. So, what are the various parts of a denture? There are mainly four parts of a denture. One being the denture base, which is intimately attached to the basal sheet area. The second are the denture flanges, which extend vertically from the occluding surfaces of the teeth to the vestibule and are partly responsible for the peripheral seal or the retention of the denture. Third, we have the denture borders, which are the limiting structures, which are in contact with the limiting structures, and they are mainly involved in the peripheral seal and the retention of the denture. And lastly, we have the denture teeth themselves. So, coming first to the anatomy of the residual ridges and their applied significance. First, we'll consider the anatomy of the maxillary denture bearing area. The maxillary denture bearing area, the anatomical structures are mainly divided into three broad categories, that is, the supporting or the stress bearing structures. The second, we have the relieving structure that need to be relieved. And the third, as the name suggests, are the limiting structures beyond which the denture borders should not be extended. Now let's consider these in a video. So first, let us consider the anatomical landmarks of the maxillary denture bearing area. So the maxillary denture bearing area has the residual alveolar ridge, the maxillary tuberosity, and the posterolateral slopes of the hard palate as the supporting structures or the stress bearing areas. The maxillary tuberosity is the primary stress bearing area and the residual alveolar ridge is the secondary stress bearing areas. The posterolateral parts of the hard palate also provide good retention because they are resistant to resorption and they are perpendicular to the forces of the mastication. We also have the rugae, which are in the anterior part of the premaxilla, and these also offer secondary support or secondary stress bearing areas. The limiting structures of the maxilla are the labial frenum, the buccal frenum. The buccal frenum are usually multiple, sometimes they can be single also. The labial frenum is generally passive and does not contain any muscle fiber attachment. The other limiting structures are the labial vestibule anteriorly and the buccal vestibule posteriorly. Posteriorly, the denture is bound by the hamular notch and the posterior palatal seal area. Hamular notch is basically a depression or dip behind the maxillary tuberosity, and the posterior limiting structure is called as the posterior palatal seal, which is a three-dimensional area which resembles the shape of the upper lip. Anteriorly, it is bound by the fovea palatine, which are mainly small elevations in the palate, which are openings for the mucosal glands in the maxilla. Now, coming to the relieving structures. In the maxilla, the prominent relieving structures are the incisive papilla over here, which contains the nasopalatine nerves in the canal. Then we have the mid-palatine raphe, which is a thin mucosal covering overlying the two palatine bones and does not contain any connective tissue, and these areas need to be relieved during the impression making and during the denture construction. So these are all the structures of within the maxilla, the rugae, and these are the limiting structure: labial frenum, labial vestibule, fovea palatine, posterior palatal seal, buccal vestibule, and the buccal frame, and the hammer notch on the distal part of the denture. And these are the relieving structures: the incisive papillae and the mid-palatine raphe in the center of the hard palate. And these are the stress-bearing areas, that is the slopes of crest of the residual alveolar ridge in the maxilla, the rugae, the maxillary tuberosity, and the posterolateral slopes of the hard palate. That brings us to an end of the anatomical landmarks of the maxillary denture-bearing area. Now coming to some atypical landmarks which I just mentioned to you. As I mentioned, incisive papilla is present in the midline in the anterior premaxilla, and it is the opening through which the nasopalatal nerves and muscles pass. The key significance of the incisive papilla is that the central incisor lie about 8 to 10 centimeters anterior to the incisive papillae, and in an edentulous ridge it becomes very crucial or very helpful in arranging the central incisors of the maxillary teeth setup. So this is one of the importance of incisive papilla. Another importance is that incisive papilla, as I mentioned, has nasopalatine nerves and vessels, and any pressure of the incisive papilla can cause paresthesia in this region of the upper lip. Now coming to the mid-palatine raphe. As I mentioned again, mid-palatine raphe is the second relieving structure that should be relieved. This is a thin mucosa covering the suture of the palatine bones, and during final impression, it should be relieved by a double spacer. Next, we move on to the hamular notch. Hamular notch are basically depressions just distal to the maxillary tuberosity, and usually the hamular notch will be palpate in the mouth is usually 1 to 2 more apical to what we see in the oral cavity. And they are limiting structures, and medially they are bound by the posterior parietal seal. So, like some of you who are posted in prostate department know, I have been telling you that to palpate the posterior parietal seal or to record accurately the hamular notch and the posterior parietal seal, you need a T burnisher. That is this instrument you can see over here, and you have to walk it over the tuberosity into the hamular notch to record that, and then it is marked in the patient mouth using an indelible pencil. The next structure, as I mentioned, was the fova palatine. They are basically useless structures, but the one significance they have is that they are sometimes helpful in determining the posterior parietal seal, especially in palates which are very shallow or extremely resorbed. It is not easy to differentiate between the hard and the soft palate. That is where they come in. You can see there are small, tiny structures which look like the eye, and for some reason they remind me of this guy, that is the stingray, the thing that killed Steve Irwin. So you can see there's a lot of resemblance between the fova palatine and the nostril of the stingray. So moving on is the posterior parietal seal area. This landmark, as I mentioned, is a three-dimensional area that resembles the shape of the upper lip, and it remains posterior to the fova palatine, bonded on either side by the hamular notch. And again, this is a very important structure because recording accurate the posterior parietal seal and scoring the area, or recording the posterior parietal seal with something like a mouth temperature wax or with a green stick compound will aid in the retention of your complete denture, and it is also helpful in reducing or eliminating the gag reflex that patient often complain of. Again, this is recorded with a T-burnisher instrument and marked with an indelible pencil. Now coming to the mandibular anatomical landmarks of the denture bearing areas. Again, they are broadly classified into supporting, limiting and relief areas. In supporting structures, we have only two areas, that is the slopes of the residual alveolar ridge and the buccal shelf area. The limiting structures are the retromolar pad, labial and buccal frenum, labial and buccal vestibules, the alveolingual sulcus, the lingual frenum, retromalahide curtain and the masseteric notch. In the relief areas, we have the crest of the residual ridge in case of mandible, the mental foramen genitubercle, and any tori that may be present, which is very practical because in Penang there is a high incidence of tori mandibularis and tori palatinis. So, sorry. Uh, so, the limiting structure in the mandibular and denture bearing area are the labial frenum. In the midline, we have the labial sulcus. Then we have the buccal frenums on either side, and then posterior to the buccal frenum, we have the buccal vestibule. Now, on the inside, lingually, we have the lingual frenum, and on either side of the lingual frenum, we have the alveolingual sulcus, which extend up to the retromolar pad. This is divided into three parts: anterior, middle, and the posterior alveolingual sulcus. Then on the terminal parts, The distal parts of the denture, we have the retromolar pad area. Medial to the retromolar pad area, we have the pterygomandibular raphe. And so coming to the label frenum. Unlike the maxilla, the label frenum in the mandible is not passive, it is active and it contains muscle fibers. So, recording the label frenum is very important as it contains fibers from the incisivus, the orbicularis oris. Now, next, the buccal vestibule. The buccal vestibule are bounded laterally by the orbicularis oris and the incisive muscles and fibers from the depressor labii inferioris. So when the patient stretches his face or makes faces, that time these three muscles cause the labial vestibule to shrink or to contract. Then we have the buccal frenum on either side. Buccal frenum also have attachments of the depressor anguli oris, the buccinator muscles, so they need to be relieved accurately, so otherwise it will affect the stability of the denture and denture will get dislodged. Then we have posterior to the buccal frenum, we have the buccal vestibule on either side, which is bounded by, as I told, the retromolar pad superiorly, medially by the ridge, and laterally by the buccinator muscle and the masseter muscle. So when the masseter muscle contracts, the buccinator muscle is pushed inwards, and this causes a notch to appear just lateral to the retromolar pad, and this should be recorded. Next, coming to the lingual frenum. The lingual frenum is attached to the lingual side of the residual ridge, and it may be very prominent in cases of patients who have a tongue tie, and this needs to be relieved, otherwise it will cause the displacement of the denture. Now, as I mentioned, the lower lingual sulcus is divided into three parts: the anterior, middle, and the posterior. So, the anterior is also called as premylohyoid, the middle is called as mylohyoid, and the posterior called as the retromylohyoid area. So the denture in the what you call the mylohyoid area or the middle part of the lower lingual sulcus should extend medially towards the tongue. That is, the denture flange should extend medially towards the tongue, that is underneath the tongue. This will provide a stable denture base and which will be held or by the denture, by the tongue, and will prevent the lifting of the denture during mastication, deglutition, swallowing, etc. So, whereas the posterior part, that is the retromylohyoid area, is sloped laterally, that is inwards towards the mandible, and such a way that it forms a S-shaped curvature when it is looked from the top. So, this S-shaped curvature is mainly because of the retromylohyoid fossa and the retromylohyoid curtain, and this should be accurately recorded in the border molding and tracing during the final impression procedures. Now, the retromolar pad is a limiting structure, and the denture preferably should not extend beyond two-thirds of the retromolar pad. Extending the denture beyond the retromolar pad will again cause discomfort, dislodgement of the denture, because we have the attachment of the pterygomandibular raphe and the superior constrictor muscle, which forms a part of the retromylohyoid curtain. So the buccal shelf area consists of loose areolar tissue, and it consists of retromolar pad area consists of fibers of temporalis, buccinator, pterygomandibular raphe, and the superior constrictor muscle, which form the limiting structures of the posterior part of the denture on either side. The buccal shell, the retromolar pad contains loose area tissue and also sometimes contain fordyces granules. So now coming to the supporting structures or the stress bearing areas. The primary stress bearing area in the mandible is called the buccal shelf area, which lies perpendicular to the occlusal plane literally and is made up of dense cortical bone, and as a result does not undergo much changes throughout the life of the patient and should be utilized as a stress bearing area. So you do not have any spacer, or preferably you remove the spacer over this area. And after this we have the what you call the slopes of the residual ulnar ridges, which act as the secondary stress bearing areas in case of prominent ridges. So as the mandible resorbs, due to the anatomy or shape of the mandible or the jaw, lower jaw, the circumference or the width or diameter of the lower denture bearing area increases. The crest of the mandible of the residual ridge is a relief area because usually it is knife edge and cannot tolerate the forces of the occlusion. Next, relieving area on the lingual side in this area is the mylohyoid ridge, which has thin underlying mucosa and that may get injured during the border molding final impression, and care should be taken. The other limiting or relieving structures in the mandible are the mental foramen, which lies between the first and second premolar, and the genial tubercle beneath the lingual foramen. Sometimes, due to excessive resorption of the ridges, the genial tubercles will be highly prominent and towards the crest of the ridge, and they need to be relieved during the denture. So, the relieving structures are the crest of the ulnar ridge, the genial tubercle, mental foramen, and the mylohyoid ridge. And the primary stress bearing area are the buccal shelf area, slopes of the ulnar ridge, and the limiting structure, as I mentioned, are the buccal frenum, label frenum, buccal vestibule, label vestibule, alveolingual, sulcus, retromolar head curtain, and two-thirds of the retromolar pad, and the pterygomandibular raphe. So that brings us to the end of the anatomy of the denture bearing area and their applied significance. So I hope you all were able to get or gain some knowledge from this lecture. So it is very important and crucial to know before you act or before you commit to the act of making a complete denture impression. So that's it. And so I hope you all understood. So this is a very subtle meme, but is very apt. And those who have made complete dentures in their clinical posting will get the joke here. That's